Hello and good morning, everyone. I've been tasked to give a brief presentation on iron deficiency. Well, on any topic, but I chose iron deficiency. So to start, um, we'll go over a brief agenda. I'll start with an introduction into the case, why it's important in primary care, a brief overview of iron deficiency with or without anemia, how the body uses and absorbs iron, and then some screening, treatments, recommendations, briefly towards the end. To start, I have no financial disclaimers or conflicts of interest to report. I wish I had a financial disclaimer. That would be nice to get paid by Big Pharma, but for now, I have no financial disclaimers. The opinions in this are my own and in no way represent the opinions of the Department of Defense, the Department of Defense Health Agency, or the United States government or US Army as a whole. So stop me if you've heard this before. Oh, hey doc, I've just been so tired lately. I don't know if I've just been sleeping bad, but like I wake up and I don't feel like I even got any sleep, and like halfway through the day I just want to take a nap. I'm always cold, I'm shivering, I'm just out of breath. And then you stop there because you start thinking about why someone is fatigued. Fatigue being a pretty common complaint. So common causes of fatigue. How'd that first one get in there? Um, so other causes, psych stuff, depression, burnout, very common to cause fatigue. Insomnia, poor sleep hygiene, those can definitely cause more of the that fatigue. Also, organic causes, stuff like thyroid dysfunction. Vitamin D deficiency is rampant here thanks to the Seattle weather. Sun goes away in September, doesn't come back until May. It's the worst. Tons of other causes. You send out your lab panel. Well, iron deficiency, I think, should be on this list. So, iron deficiency, we like to think of iron deficiency anemia, where a lot of the symptoms are from low hemoglobin levels. But iron deficiency without a low hemoglobin can have very specific symptoms. Stuff like your pica, pagophagia, eating chalk, eating ice. Um, Headache, decreased cognitive function can be symptoms of fatigue from anemia, but they can also be primary symptoms of iron deficiency. Palpitations, decreased exercise tolerance, also fatigue and anemia, but can be seen with profound iron deficiency without a low hemoglobin. Also, important, specific iron deficiency stuff. Restless leg syndrome is very specific for iron deficiency in general. Other things not noted on this specific picture is the angular chelosis. That's the drying, inflammation, redness at the corners of the lips, and then some nail changes like nail brittleness. Um, those can be symptoms of iron deficiency, just completely absent of any anemia. So I'm going to be briefing off of some pictures here because I don't like hitting people with a lot of words. So we have how the body uses iron. So iron is stored in enterocytes in the GI tract and also in macrophages throughout the body, specifically, most specifically, liver, kidneys, um, that area. And it's stored inside those cells bound to ferritin. Normally in the body, see the top area labeled A. Um, when it needs to be mobilized, it comes out through ferroportin, binds to transferrin, and then can be mobilized to the bones where you produce your red blood cells. Those red blood cells are produced, spat out, and it can also be carried to muscles. Most of the iron in our body is actually stored in hemoglobin and myoglobin in our muscles, but we do have a functional pool that we can always pull from. So iron deficiency works in two ways. You can have either absolute iron deficiency, where your body just doesn't have enough iron, which includes in its iron stores in macrophages and enterocytes, in which case you don't have a lot to pull from to go into the bones to make these red blood cells. So the red blood cells and the lack of hemoglobin and the symptoms are due to you just not having enough. Additionally, you can have a functional iron deficiency. Functional iron deficiency saying, hey, your stores are good, your bank account's full, but you can't pull that out. One of the biggest causes of this is chronic inflammation. One inflammatory marker that's a little bit less important, but very important for iron deficiency specifically, is this protein called hepcidin. Hepcidin actually decreases the activity of this ferroportin, so you end up not pulling ferritin and iron out of the cells into this transferrin. So you have it, but you can't pull it out to mobilize it to the bones to make red blood cells. I like this picture because it shows you a couple of causes of iron deficiency, and it kind of gives you a little bit of a flow chart here at the bottom of absolute iron deficiency versus functional iron deficiency. Because you can see when it is absorbed, it gets pushed towards the storage pool over here, or it gets immediately mobilized. So some general causes of this: inadequate intake. So you have your vegetarians, vegans, people who don't eat enough iron. Um, Fun fact: people originally thought like broccoli and spinach were superfoods because they had, just a ton of iron, like 10 times the amount of like beef. Well, it's funny because in the actual studies, what happened was whoever found out how much iron was in these vegetables actually misplaced their decimal point. So it actually doesn't have as much iron, but still has some. I just thought that was interesting. Additionally, increased body needs. So people who are, elite athletes who have to mobilize a lot of this to build muscle or to increase their cycling blood um, can run into iron deficiency. People who get pregnant, um, they suddenly need a lot more iron to, build another human. Um, that can put a drain on your iron supplies. Additionally, you can get chronic blood loss. Your body can still build those red blood cells, so you don't end up having an actual anemia, a low hemoglobin. However, you might have increased inflammation, such as with, cancers, um, or you just aren't replacing that store of iron, so you're making blood cells, but they're just not great. Also, reduced absorption. People who are chronically on proton pump inhibitors or gastric antihistamines, your pepsids, your omeprazoles, that can reduce your absorption of iron. People with H. pylori infections, caffeine, super high caffeine use can actually lead to reduced absorption, and GERD without any treatments can also reduce your absorption of iron. Also, some other stuff like celiac disease, chronic bleeding, hookworm infection, which I guess is kind of cool, but we're probably not running into that in the Pacific Northwest. Also, inflammatory diseases, chronic inflammatory diseases would increase those inflammatory markers, such as hepcidin, which is going to lead to more of a functional type of iron deficiency, but can still lead to misuse of the iron in your body. So screening, you suspect someone who's iron deficient. You don't know if they're anemic, you don't know if they're iron deficient, they're just tired, and you want to check this out. So I like this flow chart here. Patients with suspected iron deficiency, you can check their hemoglobin levels. Now, do they have a normal hemoglobin? If they don't, if it's a low hemoglobin, you investigate that accordingly. So, you see anemia, you think, blood loss, um, vitamin B12, folate deficiency, chronic inflammation, but you can also still suspect iron deficiency with that anemia. So even going down this no, you might still want to use this yes flow chart to help you investigate. So let's say they have a normal hemoglobin and you still think, okay, maybe it's iron deficiency without anemia. So the two biggest labs you want to check are their ferritin and their total saturation. So the ferritin is a measure of total body iron. That is what iron is bound to inside the cells when it's not on hemoglobin or myoglobin, or in the bloodstream. So a total ferritin is very useful. It's a little bit less useful in someone with chronic inflammation, or someone who is more advanced in age, someone who's older. They will produce more ferritin, so that could be falsely elevated. But in a military population, ferritin is generally good. So you go down the flow chart. Does the patient suffer from a chronic disease? If no, so the ferritin of less than 30 micrograms per liter is generally the most sensitive and specific for iron deficiency symptoms. There have been past data has shown that 15 is, a lot more specific, but it fails to capture a lot of patients who have iron deficiency symptoms. But that 30 tends to capture them more without a decrease in false false positives. Um, so if they have a ferritin less than 30, you can assume iron deficiency without anemia, and then you can treat accordingly. Um, if their ferritin is above 30, you can probably consider other causes. If they suffer from a chronic disease, a ferritin of less than 100, you assume that the ferritin is falsely elevated anyway. So if it's less than 100, you can consider iron deficiency. If it's not, you can check their total saturation because maybe they have a falsely super elevated ferritin, but their total saturation is still low. Um, So additional screening considerations. OBGYN considerations such as pregnancy, you always want to make sure that there's proper iron. Um, Low iron states in pregnancy have been associated throughout literature with poor prognoses and poor lifetime health risks for the actual baby. Additionally, uh, chronic blood loss. So when you're considering someone who has iron deficiency anemia, um, you can consider chronic blood loss, such as like GI causes, but then also consider, heavy periods. Have they just recently started an irregular cycle with a lot of bleeding? So that is something that you can definitely ask about in the history and physical. Additionally, something that goes or under recognized is the use of iron screening in preoperative risk stratification. So, preoperative iron deficiency without anemia has been shown to increase the risk of post-op infection, fatigue, transfusion, anemia after surgery. And so there is more and more of a shift, especially with like anesthesiology, doing their pre-op risk stratification in checking iron levels, checking iron sats. Um, One of the now current recommendations for people who are kind of more in the know about checking iron is to actually balance out that iron deficiency prior to any major surgery, such that their ferritin is back to like above 100. Um, and that has been shown to actually decrease a lot of morbidity mortality in these patients. So I would recommend anyone who is going for some sort of major surgery that they're planning, I would add iron studies as a routine pre-op evaluation lab. So let's talk about treatment, just general treatment. So first thing you want to always check is conservative management. Let's check reversible causes and behavioral modification. So if they have chronic inflammation, you might not even need to really attack the iron as a treatment. Um, Working up that chronic inflammation can potentially liberalize any of those iron stores that are being blocked by hepcidin. Also, chronic blood loss. You definitely want to reverse the blood loss. If someone is having dysmenorrhea or particularly heavy periods, maybe starting oral contraceptives, sending to OBGYN, NSAIDs, stuff like that, because you can pump the body with as much iron, but if they keep losing blood, it's not going to be super helpful. Also, diet modification. If someone is vegetarian, vegan, and hasn't had any iron-rich foods in a long time, that's a good place to start by saying, "Here, have some spinach." Um, that could help. Um, Next thing would be iron supplementation. This is your oral iron. That's your ferrous gluconate, ferrous sulfate, ferrous fumarate. Those can be poorly tolerated. They have a lot of GI side effects, constipation, nausea, sometimes diarrhea, abdominal pain is a big one. Um, they really can be poorly tolerated, and most people will stop them for a GI complaint. Um, ways to increase that is to is to advise taking it with some sort of vitamin C that helps it actually absorb and causes it to not go as far in the GI tract, which can cause irritation. Um, and they also make formularies with vitamin C. I like Vitron C. That's an over-the-counter iron supplement that actually has vitamin C with the iron supplement and helps. That is used in the standard cases for IV iron infusions. So that should only be used in refractory iron deficiency with or without anemia. Um, so someone who can't tolerate oral iron and is still profoundly iron deficient, or you've been giving them oral iron and they're not responding to it, that's when you go for IV iron infusions. There's recommendations for dosages and IV infusion regimens on UpToDate if you're curious. Um, and then red blood cell transfusion. You start evaluating someone for iron deficiency. They're just really tired. They're getting through their day, and then you get a hemoglobin, and it's 6, and you freak out and you send them to the ED for a blood transfusion. Well, that's actually not recommended in the case of iron deficiency or iron deficiency anemia, as long as they're hemodynamically stable. So if they're unstable or just intolerant to like any physical activity, I blood transfusion makes sense. But for someone who is showing mild symptoms, people can live down at a hemoglobin of 6, 7, with just a lot of these symptoms, but no instability. So just be mindful of freaking out when you see that 6 if they're hemodynamically stable. So in these treatments, what you're going to be doing is you're going to follow their lab results for the first 6 to 8 weeks from starting therapy. If you start oral iron, I would check in about a week later just to see how they're tolerating the iron, because at that point, most people will figure out if that's right for them. But in 6 to 8 weeks, you're going to repeat labs. You want to target a ferritin of greater than 100, that should say micrograms per liter. That's a lot of ferritin. Greater than 100 micrograms per liter. Um, and you want to check some other inflammatory markers, CRP, and then check a CBC with diff. So the anemia can rebound pretty quickly, but the ferritin is actually your goal number. That's what you want to see to adjust response. Once you reach that target ferritin, you want to still follow up routine labs in maybe 6 to 12 months just to evaluate and see if they're pushing back towards iron deficiency, especially in a population that you think could become pregnant or wants to become pregnant. You want to really keep track of that. So that concludes my general presentation. Here are my references. Why is this important to me? So this is my wife. In addition to being an absolute weirdo, a published author, a current psych resident, um, she also ate ice for her whole life. Thought it was behavioral for a while when we first started dating. Everyone in our friend group was basically yelling at her to get her iron checked, and she said, "No, it's fine. My ice isn't a problem." Tell me, does that look like the face of someone who doesn't have a problem and can quit anytime she wants? Well, she got some really bad symptoms at some point. We told her to get checked, and she had a ferritin of 2, which I think is hilarious because that's the lowest ferritin I have ever seen. And yeah, this is my wife who doesn't have a problem and can quit anytime she wants. She got iron infusions, which I think is cool. And that concludes my presentation. Thank you.